Moving on to the last plenary lecture for the day, that is on cardiac MRI in cardiomyopathies and myocarditis. May I call upon consultant cardiologists Dr. Prakash Priyadarshan and Dr. Ruan Munasinghe to chair the sessions and introduce the speaker.
Good evening, everybody. This is the last lecture for the today. So it's a very interesting section because in any film, the climax is the best. So I think this is going to be the best lecture for all who's waiting. Okay. So first of all, I'd like to introduce our speaker. He's well-renowned Dr. James Shamrock. He's consultant cardiothoracic radiologist, University Hospital, Southampton, president. He's the president of the BSc and BSc CT. Dr. Shamrock was appointed as a consultant cardiothoracic radiologist at University Hospital, Southampton in 2019. His interest includes adults and pediatric cardiac CT MRI as well as thoracic imaging, particularly lung cancer imaging and screening. He is the current president of the British Society of Cardiovascular Imaging, British Society of Cardiovascular CT. So, we invite Dr. Shamrock for his enlightening lecture for Sri Lankan College of Cardiology.
Well, good afternoon, and thank you very much for the kind invitation from the Sri Lankan College of Cardiology to speak at your meeting. My name is James Shamrock. I'm a consultant cardiothoracic radiologist at the University Hospital Southampton and the current president of the British Society of Cardiovascular Imaging. I'm going to be talking about cardiac MRI and cardiomyopathies and myocarditis, which is a large topic, certainly to cover in 20 to 25 minutes. So it will be a whistle-stop tour of just sharing my experience of imaging these conditions with cardiac MRI. I'd like to start by going through some of the sequences that we have available to us in cardiac MRI, which we use for imaging for cardiomyopathy. And as you can see on this slide here, there are several different sequences. We have our standard cine sequence, which is a steady state free position, which allows us to look at the differentiation between myocardium and blood pool and assess function. We have color tissue mapping, which I'll go on to in a little bit more detail later, which is integral to the expansion of cardiac MR for the investigation of cardiomyopathy and myocarditis. Late gadolinium enhancement, which is a fantastic tool for looking at fibrosis within the myocardium. We can do real-time imaging, which is a mimic really of echocardiography. The resolution is not as good, but it does allow us to image patients who have arrhythmias and sometimes look at the dynamic changes in cardiac size during respiration. We have black blood sequences, which allow us to look for specific conditions like myocardial edema. And then we have other sequences where we can tag the myocardium to see how well the contractility works, as well as flow studies looking at myocardial flow through blood vessels and throughout the cardiac chambers. I just want to focus a little bit on the parametric tissue mapping, because we'll come back to this quite a lot as we discuss the different conditions. One of the things that cardiac MRI is so very good at is tissue characterization. And the reason it can do this is because of the physical properties of tissue once put inside the magnet. You will be aware that essentially MRI scanning is looking at free protons in water, and they are spinning in a certain direction. As soon as we put them into the magnet, they align along the bore of the magnet, and then we use radio frequency pulses to knock them off axis, and then we turn those pulses off and we allow those spinning protons to return to baseline. And as they return to baseline, they give off a signal which we can measure. Now, interestingly, there are a variety of different ways in which that relaxation happens, and we can exploit that because there are certain patterns of relaxation that gives us information about myocardial tissue. The terms that you'll hear me use are T1 weighted, or T2 weighting, or T2 star. And these numbers represent the type of myocardial proton spin relaxation. And the important thing is that they are different physical parameters, and T1, T2, and T2 star mean different things. And for MR, what we'll talk about is that T1 and T1 mapping, and this is a T1 map showing the T1 signal for individual pixels within the myocardium, are a marker of myocardial fibrosis, expansion of the extracellular space, and we will see that the T1 values will go up with increased fibrosis. It will go up if there's increased tissue fluid, but it will go down if there's any evidence of myocardial fat. T1 relaxation time will be shorter, as opposed to T2 mapping, which is very, very sensitive to water and therefore is a very good sequence for looking at myocardial edema. And T2 star mapping is another relaxation parameter, which is very, very sensitive for myocardial iron deposition. And I'll talk about that a little later when we move on to iron overload cardiomyopathy. Well, now coming on to cardiomyopathy, this is the WHO classification, which you'll be more familiar with than I. And this is how it's broken down into ischemic cardiomyopathies, then the non-ischemic cardiomyopathies with hypertrophic cardiomyopathy, restrictive cardiomyopathy, dilated cardiomyopathy, then the arrhythmogenic cardiomyopathy, and then some of the unclassified ones such as non-compaction, Takotsubo, and chemotherapy-induced cardiomyopathy. And because of the time restraints, what I hope to do is run through most, but not all of these conditions and show how we use MRI to help us investigate these conditions. So we're going to start with hypertrophic cardiomyopathy. As you'll be aware, it's the commonest inheritable cardiac disorder with an incidence of about 1 in 500, autosomal dominant inheritance, and it has myocyte hypertrophy and disarray, and you will be seeing this on a regular basis in your echo, I'm sure. Manifestation normally comes in adolescence and early adulthood, and symptoms relate to systolic and diastolic dysfunction, arrhythmia, left ventricular outflow tract, and sudden cardiac death. There are a variety of different phenotypes. We can have asymmetric left ventricular hypertrophy, we can have obstructive hypertrophy, apical hypertrophy, mass-like or symmetrical. So there's a real variation of phenotypes of this condition. And one of the biggest challenges we often get faced, and I'm sure you face this with your echo practice, is how do we differentiate hypertrophic cardiomyopathy from physiological hypertrophy related to athletic training, aortic stenosis, or hypertension? Well, this is an example of asymmetric hypertrophic cardiomyopathy on cardiac MRI. And you can see here we've got a 4-chamber, 3-chamber, and 2-chamber view showing clear asymmetric left ventricular hypertrophy with some involvement of the right ventricular myocardium as well. Typically, we would look to see a mean ratio of septal to lateral wall end diastolic thickness of 1.5 to 1 in hypertrophic cardiomyopathy compared to 0.9 to 1 in normals and 0.8 to 1 in left ventricular hypertrophy. We see left ventricular outflow tract obstruction in up to 20 to 30% of cases. And what is also quite common is we see some mid-wall late gadolinium enhancement, showing fibrosis within the mid-wall of the myocardium. And this is an example of some of the delayed enhancement that we see within hypertrophic cardiomyopathy. And one of the typical features is seeing focal hyperenhancement here within the anterior and inferior RV insertion points. Myocardial tagging is a sequence which I discussed earlier on briefly, and it shows grid lines across the myocardium, and you can see how they deform throughout the cardiac cycle. And what's interesting here, within this hypertrophic myocardium within the septum, you can see relatively little deformation of the grid line, showing that although the muscle is thickened there, it is not contracting in an appropriate way. One of the reasons why I think MR is useful in hypertrophic cardiomyopathy is the presence of late gadolinium enhancement. And in actual fact, there is a lot of emerging data now saying that this has a significant prognostic impact. And you can see here in this one study that in patients who had no late gadolinium enhancement, therefore no focal scarring associated with a hypertrophic cardiomyopathy, the incidence of sudden cardiac death events was much lower than those patients who had a significant volume of late gadolinium enhancement. And this will be a common theme throughout this talk. It does appear that the more fibrosis or scarring you have, as evidenced by late gadolinium enhancement, the worse your prognosis is across most of the cardiomyopathies we're going to be discussing today. Late gadolinium enhancement of greater than 15% of LV mass demonstrated a 2-fold increase in sudden cardiac death. So it really is a significant finding if you do see scarring in these patients with hypertrophic cardiomyopathy. And as a consequence of that, we're now seeing the role of cardiac MRI and hypertrophic cardiomyopathy come into guidelines. And these are the ESC guidelines that were published back in 2014, talking about the role of MRI. And it's clearly recommended class 1 or class 2A conditions for a variety of things, specifically mentioning that the role of late gadolinium enhancement is useful in this condition. And I want to move on to dilated cardiomyopathy, 36 per thousand in the population. It's the second commonest cause of heart failure after ischemic cardiomyopathy, and is the commonest indication for transplant. As you'll all be aware, 50% there's no cause found, and 20 to 30% of cases they are familial and attributed to known genetic abnormalities. Well, I think the question that we most get asked in our practice is differentiating a dilated cardiomyopathy into ischemic or non-ischemic, or if there's any features to suggest the etiology of the dilated cardiomyopathy. And this is a really nice example of the different patterns of late gadolinium enhancement that we see in patients with dilated ventricles. On the left-hand side here, there's clear subendocardial late gadolinium enhancement involving the inferior wall and the lateral wall, and this is classic pattern of subendocardial infarction in the presence of a dilated left ventricle, and therefore would be an ischemic dilated cardiomyopathy. If you compare that to this mid picture here, where you can see that again we're getting clear evidence of late gadolinium enhancement within the mid interventricular wall in that linear stripe distribution, which is very different to the subendocardial scarring pattern we saw, and this is a classic pattern for DCM, that mid-wall stripe within the septum. You can then compare this to this panel on the right-hand side, where we see foci of late gadolinium enhancement in the subepicardium, both here in the lateral wall and here within the septum, and this is much more in keeping with a pattern of myocarditis. Now, as I said, with hypertrophic cardiomyopathy, the same is true with dilated cardiomyopathy. The presence of fibrosis, as evidenced by late gadolinium enhancement, does infer a worse prognosis, as you can see here. Cardiovascular mortality or transplantation is much more likely if there is evidence of fibrosis on the cardiac MRI. I'd now like to turn my attention to restrictive cardiomyopathy. And as you can see here in this three-chamber view, we've got a thickened left ventricle, which has got a very stiff relaxation pattern. And some of the conditions that cause restrictive cardiomyopathy that we get asked to investigate: amyloidosis, hypertension, aortic stenosis, hemochromatosis, and Anderson-Fabry disease. And we'll just look at some examples of that in a second. So this is an example of a patient with severe aortic stenosis and another patient with hypertensive cardiomyopathy. And you can see with the cine imaging that we have and the tagged images here, you can show how restrictive the myocardial relaxation is, the limitation of impaired longitudinal contractility. So they provide excellent subjective assessments of myocardial contraction and relaxation. If we look at specifically amyloid in this particular case, a topic that we could have given a whole talk on 20 minutes alone, this is a condition where, as I'm sure you're all aware, you get deposition of amyloid protein throughout the myocardium, which causes left ventricular hypertrophy as well as right ventricular hypertrophy and some thickening of the atrial walls. And then there's associated heart failure with that, as you can see in this patient with a shallow pericardial effusion. But what's most interesting about amyloid with cardiac MRI is actually it creates quite a striking pattern of late gadolinium enhancement, as you can see here on the bottom panel. We've talked about the patterns associated with a DCM and an ischemic cardiomyopathy, but here you can see diffuse abnormality of the late gadolinium enhancement throughout the myocardium. Sometimes described as almost a circumferential subendocardial late gadolinium enhancement with a kind of relatively preserved strip in the mid-myocardium and then a subepicardial ring of late gadolinium enhancement, described sometimes as a zebra striping. When our radiographers are acquiring late gadolinium enhanced images and they're looking to try and work out what's normal myocardium versus abnormal myocardium, these are the cases when they're training they have most difficulty with, because there's really very little normal myocardium to compare with. Looking at parametric mapping in the role of amyloidosis, there's good evidence that actually an assessment of the extracellular volume in amyloidosis shows that an increasing extracellular volume leads to a poorer prognosis. And this is one such study that looked at amyloid in patients with transthyretin amyloid and light chain amyloid to compare that. And we are seeing an increasing number of patients with that amyloid coming through our practice, particularly the transthyretin amyloid in the older population, and using late gadolinium enhancement and parametric mapping, we're identifying more and more of these patients. Just quickly want to compare how MR can show the difference between a restrictive versus a restrictive cardiomyopathy versus a constrictive pericarditis. Here on the left-hand side is a case of amyloid we've just seen in real time with a very thickened myocardium, but very little variation in the morphology of the ventricles during respiration. If you compare that to the right panel, where actually we've got the patient taking a deep breath during the acquisition on these real-time acquisitions, and like you see in echo, you can see as the diaphragm descends, there is flattening of the interventricular septum, implying ventricular coupling in keeping with a constrictive physiology. So we are not infrequently asked in patients who've got pericardial calcification on CT and symptoms of constrictive pericarditis to do an MRI to see if we can demonstrate this ventricular coupling and likely physiological impact of constrictive pericarditis. The next condition I want to talk about is iron overload cardiomyopathy. This was one of the real success stories of early cardiac MRI to see how it impacted not only on the investigation but also in the prognosis of patients. So, as I'm sure you're aware, the toxic effects of iron overload within the myocardium causes cardiomyopathy. We see it a lot in beta thalassemia patients who require recurrent transfusions, and it can be treated with chelation agents, but these are expensive, so not everyone gets that therapy. What cardiac MRI can do is actually assess the amount of iron within the myocardium, and then depending on the volume of iron there, can actually provide evidence to clinicians as to whether they should start individuals on chelation therapy and therefore avoid the onset of iron overload cardiomyopathy. And this bar chart, I think, is quite extraordinary. It demonstrates those people who were dying associated with iron overload cardiomyopathy. Over the last, since the 1950s up to the 2000s, and you can see that the largest proportion between 1995 and 1999 of deaths was because of iron overload itself. Whereas actually, following the introduction of cardiac MRI, identification of those patients who were beginning to store iron in their myocardium and then start them on appropriate chelation agents has resulted in a significant reduction in the volume of heart failure deaths within these patients. This is the sequence that was used for the identification of myocardial iron before tissue parametric maps came on. It was looking at T2 star signal decay, and you effectively look at the myocardium at the same point over a number of time points to see how quickly the T2 star signal decays. The higher the iron overload, the more rapid the decay signal, and that is measurable when looking at a graph like this. And we were able to identify which patients had iron overload before they had symptoms, and therefore recommend that they start on appropriate chelation therapy. And this is really interesting. You can see here there's really very good correlation between T2 star relaxation time in patients who have heart failure. And if you had a relaxation time of greater than 10 milliseconds, you were normal. However, if the relaxation time was less than 6 milliseconds, there was a much higher incidence of heart failure in these patients. So the correlation between this measurement and symptoms was very impressive and led to appropriate chelation therapy. Now moving on to Takotsubo cardiomyopathy. It's about 2% of chest pain presentations that we see, more common in postmenopausal women. Complex pathophysiology, as I'm sure you're aware, often associated with stress triggers and can go undiagnosed. What's key about it is the morphology of the ventricle in these patients who present with heart failure in this stress-induced cardiomyopathy, and it's this apical ballooning, hence the name Takotsubo, the kind of Japanese octopus pot, which had this morphology of a narrow neck and a wide left ventricle. And you see here on MRI, beautifully exampled, the preserved basal function but global hypokinesia of the mid to distal left ventricle. And what's also useful is looking at the other myocardial sequence, MR sequences that we can do. You can see that there is some edema associated with this that corresponds to the wall motion abnormality. So as you can see here in the basal function, very little in the way of myocardial edema, but on these T2 weighted sequences, you can see there's some subendocardial edema at the area of the wall motion abnormality. And then perhaps even more importantly, late Gadolinium enhanced imaging showing that there's no evidence of myocardial infarction, there's no subendocardial scar, but there is a slight haze in the area of wall motion abnormality, and that too corresponds to the edema that's associated with this condition. But as you're also aware, and which MR demonstrates beautifully, if the patient survived the acute phase, the myocardium recovers quickly and spontaneously. And this is an example of a patient who had clear ballooning dysfunction of the apex here, and then 3 months later had returned to near normal. I just now want to touch on arrhythmogenic cardiomyopathy or dysplasia. This is a condition that we often get asked to investigate in those patients who present with some right ventricular dysfunction, but clearly it can involve the left ventricle as well. And back in 2010, there was these modified task force criteria were produced, which looked at a variety of different appearances of the myocardium, family history, ECG criteria, and therefore to get a diagnosis of arrhythmogenic cardiomyopathy, you needed 2 major or 1 major and 2 minor or 4 minor criteria. Now, as a result of that, MRI alone cannot make the diagnosis, but it can help, as there are some features on MRI that add to these criteria, and they are based around the size and the function of the right ventricle. And as you can see in this particular case, clearly the right ventricle is dilated, but in addition, there is evidence of wall motion abnormality, focal aneurysm formation within the right ventricle itself, which is corresponding to areas of focal fibrofatty infiltration within the right ventricle. And you can see here on this slide what constitutes a major criteria and a minor criteria, which is variable depending on whether you're a man or a woman. Now, interestingly, it is possible on cardiac MRI to demonstrate areas of focal scarring, as we can see here in this patient with a little focal area of late gadolinium enhancement within the RV3 wall and the fat infiltration within the wall. But these are not as sensitive, and as a result have not made it into the criteria for ARVC. So we will look at them with cardiac MRI, and we will do fat sensitive sequences and scar imaging and report it. But actually, when it comes to major criteria, they do not constitute part of the major or minor criteria, and therefore these are just adjuncts in helping making the diagnosis. And I think the reason for that is because these aren't particularly sensitive. Because the RV3 wall is so thin, it is possible that you could miss these features on MRI, and therefore we rely more heavily on the dysfunction of the right ventricle and the size of the right ventricle itself. What about cardiac sarcoidosis? Well, you see clinically recognizable cardiac sarcoidosis in about 5% of people who have systemic sarcoidosis, but it's much higher apparently in autopsy series. And the MR findings are, as you might expect, you would expect to see adenopathy within the mediastinum. You'll see abnormal lung parenchyma. You might see nodules in the spleen. Within the myocardium, there are quite characteristic appearances, and it's largely based around the late gadolinium enhancement. We get mid-wall and subepicardial late gadolinium enhancement. You may see some evidence of myocardial edema. The myocardium may be thickened or thinned, depending on whether it's active inflammation or kind of burnt out fibrotic sarcoidosis, and there may be normal LV function or it may be impaired. This is examples of the sort of extra manifestations you might see in a patient who's got sarcoidosis, typical pulmonary parenchymal infiltration with associated adenopathy, and a nice example here of the nodules you can sometimes get in within the spleen. But the reason we do cardiac MRI is we've been looking specifically for evidence of cardiomyopathy associated with sarcoidosis, and these are some examples of the patterns of late gadolinium enhancement we would see. This kind of flame-shaped appearance, which is predominantly subepicardial, but extends towards the subendocardium, quite different from the pattern of ischemic scar that we've seen, and also very different from some of the hypertrophic cardiomyopathy and amyloid patterns of late gadolinium we've seen. Typical distribution is we often see it within this basal anterior septal wall, and it can be quite nodular, and in a coronary artery territory, you can see multifocal areas of this subepicardial enhancement. So I think sarcoid is a condition that we do get asked not infrequently to investigate in those patients who've got known pulmonary sarcoidosis. They've presented with some ECG abnormalities, potentially second or third degree heart block, and we're now looking to see if they've got these sorts of patterns of scarring to confirm the presence of cardiac sarcoidosis. So I'm coming towards the end from this whistle-stop tour, and I now just want to focus on a couple of slides about cardiac MRI and myocarditis. And there's one paper that I really would encourage you all to take a look at, and this is this paper, which was the modified Lake-Louise criteria paper that was came from Matthias Friedrich and his team in Canada, looking at the sequences we have available in MR and how sensitive and specific they are for the identification of myocarditis. And what you can see here, we've got a variety of different sequences that we can use. We've got T2 weighted black belt imaging, we've got parametric maps, we've got early gadolinium enhancement, we've got late gadolinium enhancement, and we've also got extracellular volume assessment. And what this grid here shows us is looking at all of those different techniques. They've identified those research trials that have used these techniques for evaluating myocardial edema and inflammation. And initially, we were using T2 weighted sequences and late gadolinium enhancement and early gadolinium enhancement, and the results were mediocre at best. But with the more recent studies, we're seeing now using T2 mapping, T1 mapping, and late gadolinium enhancement, we're getting much better diagnostic accuracy. This is the area under the curve here with these sequences. And so as a result, this paper was written saying we need to modify the way we diagnose myocardial edema because we've got more sensitive techniques now, and therefore we need to kind of make most of that and put that into guidelines. And this is the central illustration from that paper. And effectively what they've shown here is that the main criteria for the identification of myocardial edema is showing regional or global increase in native T2 or T2 mapping, and to show those patients who've got non-ischemic myocardial injury a generalized increase or regional increase in T1 weighting or late gadolinium enhancement. So if you've got elevation of T2 and elevation of T1 or elevation of T2 and late gadolinium enhancement, that is associated with myocardial edema. And the supportive criteria, they say, which are not absolutely diagnostic, but certainly would support the presence of acute myocardial inflammation, or if you're seeing global wall motion abnormality or evidence of pericardial effusion and some pericardial thickening. So I'm going to finish there. I appreciate that was a real whistle-stop tour. It's just really say, cardiac MRI is a multi-parametric assessment of myocardial disease. It can look at function, it can flow, and particularly it can look at tissue characterization with myocardial mapping and late gadolinium enhancement. And I think those are the real cornerstones of identifying myocarditis and cardiomyopathy. The evidence-based is growing on how these imaging biomarkers can determine prognosis and appropriate therapy. And we'll see guidelines changing and introducing many cardiac MRI for most of the conditions that we've been talking about over the last 25 minutes or so. Thank you very much.
On the behalf of Sri Lanka College of Cardiology, I would like to express our sincere thanks to Dr. James Shamrock for that informative lecture regarding CMR in myocarditis and cardiomyopathy. If you have any questions, you can ask from Dr. James Shamrock. Shall I ask one question regarding cardiomyopathy? What is the clinical significance of doing CMR in non-compaction cardiomyopathy? Is it indicated or in current practice?
Thank you very much. Yes, I mean, 25 minutes wasn't very long to go through all the cardiomyopathies, and that's one I didn't specifically discuss. But yes, we do get asked about imaging for non-compaction cardiomyopathy if there's been some features identified on echo, and there are specific criteria. So if we will measure the compaction to what on the is suspicious for non-compaction, but it does have cardiac isolated non-compaction cardiomyopathy.
We have some technical issues, Dr. James Shamrock.
Sorry, I think the internet connection is pretty crude. Crashed. So I think I'm back now. Appreciate the internet.
I think we have some technical issues from in regard to the internet. Therefore, we will conclude this symposium. Again, on behalf of Sri Lanka College of Cardiology, I would like to express our sincere gratitude to Dr. James Shamrock. That is a very informative lecture. And again, thank you very much.
Thank you very much, Chairpersons. So we have come to the end of the first day of our annual academic sessions. On behalf of Sri Lanka College of Cardiology, I am very grateful to all the speakers, chairpersons, as well as the participants. We are coming back. We are meeting you back on tomorrow, and I hope all of you will join us tomorrow as well. Thank you very much, and have a very pleasant evening.